Our guest is Dr. Ryan Badwani. He is a board-certified physician in pain management, and he works at the Spine and Nerve Center of the Virginias, and he works right along with Dr. Tim Deer, who was on this program about 20 years ago when he started some of these innovations that we're going to talk about today. Welcome, Dr. Badwani.
Oh, it's truly a pleasure to be here. Thank you for having me.
What is an interventional spine physician?
Well, I think it's an interesting term. About 20 years ago, when Dr. Deer was on this show, the profession looked a little bit different. We were changing the way things were working because it was more of a pharmaceutical-based approach at that point. And now we've transitioned to a more minimally invasive spine and nerve approach. So what does that really mean? It means that our goal is to change the way people function with their pain rather than to mask it up with just medications. And so the goal now of our profession is to really work with the patient, their functional goals, and to see what can we do based on the tools that we have available to help them be more functionally cognizant in their day-to-day life.
So we're not just treating the symptom of pain, we're trying to cure what's causing the pain.
So type of the interventions we do, yes, they do help cure some of the problems, but it's also that they make it more manageable without using the just opioid-based approaches that were taken in the past.
So that's what makes spine and nerve treatment so important.
Absolutely. So the field's really going under a lot of transition, especially over the last 5 to 10 years. Like I said, in the past, most of the tools we had were pharmaceutical-based approaches like medications or pain pumps. And now we've transitioned where we have tools that actually go in and fix the problems like you were mentioning.
So that brings us to what our topic is. It is spine and nerve pain.
Absolutely.
And you're going to tell us how to take care of that.
I will try.
Okay, so what is minimally invasive interventional spine treatment take into account?
Well, we would need a couple days to go over that entire topic. But I'll try to share with you some of the main things that we see in our patients, right? For example, our patients most commonly come into us when they're either referred by their spine surgeon or their orthopedic surgeon or their primary care doctor. Even podiatrists and chiropractors send a lot of patients to us. And a lot of these patients, they may have gotten hurt on their job and they want to return back to full functionality, but they're no longer able to take part in that because of their ongoing pain. Or even simple things like, they want to be able to play with their grandkids or go back to doing their day-to-day chores. And so what we've had to figure out is, how can we use the tools we have to manage these things? So one of the most common reasons we see these patients is because they previously had a surgery in their back. And once they had this back surgery, now they're having ongoing pain in their back or now in their legs, and they're feeling weakness in their legs or feeling pain going all the way down their legs that limit them from doing the things that they want to do on a daily basis.
So you have this model of the spinal column here. What is that for?
Well, this model here is to kind of show where some of these tools come into play, right? So how I was telling you, with this spinal cord model, the reason I wanted to bring it in is to show that the spine is really dynamic. And as we age, either you have arthritis or injuries that develop that kind of change the way the spine functions. So some of these tools that we have, like I was telling you, the electroceutical approach, it's called a spinal cord stimulator. So, Dr. Deer from our practice, he's one of the leaders in the field, and he's helped to really promote its development and the evolution of this technology. So what does this technology really do? Well, we basically take a really thin wire, it's as thin as the size of a hair, and we place it right next to the nerve in your spine. And so it goes right next to that area, and it's implanted in there, and it talks to that nerve. And basically, it tells your nervous system, it tells your brain to turn off that pain signal. And so that way you're able to more actively take part in physical therapy and recover from part of that injury that you may have experienced.
So you stimulate the nerve root so that the pain stimulus doesn't get to where it normally is, the intensity.
Absolutely.
So how do you activate this wire?
Well, the wire, once we put the wire in, the wire is actually connected to a small computer like this. So this computer is connected to the wire just like this. It goes into the epidural space,
Yep.
which is right outside the spinal cord. and it communicates with this device. So this is a small computer that's implanted in your body.
Okay.
And the really neat thing is that this simple device is actually controlled by a device like your iPhone. Your phone can actually control this device, and it allows us to actually program the sensation that you're experiencing. So anytime your sensation
changes. So the
changes.
patient can control the pain by increasing the stimulation.
Absolutely.
Son of a gun. Excuse me. Fantastic.
And the beauty of it is that this technology has evolved so much that now we can use telehealth and remote technology to actually control it, so you don't even have to come into our office.
That's like the atrial fib things and all, where you keep your little...
Absolutely.
Keep it by their bedside.
Absolutely. So yeah, that's kind of where some of this technology evolved, from where we had electroceutical-based approaches for cardiac care. That same technology has now evolved to understanding how the pain response in the body is generated.
Are there any contraindications to doing this? And every time you go through to the airport now, that thing's going to show up.
It may show up, but typically it doesn't really, light up the scan or anything like that.
Do the patients carry a card? I have to carry a card from my tent.
In many situations, the patients carry a card. Some of the technologies are MRI compatible, so for patients who need ongoing MRI screenings, they are able to get some of those technologies in place that allow that. But really, the beauty of it is that it's really specified to the type of pain you have. And so you can do something like a spinal cord stimulator, which can target, the generalized spinal cord, or a specific dorsal root nerve, which targets a specific area in your body. But even more so, we have something called a peripheral nerve stimulator. What that means is that we can actually take a wire, again, it's a really thin wire we put right next to the nerve in your body, whether it's near your shoulder or near your knee if you have knee pain, or near your foot, and basically talk to that nerve, again, with a generator, a computer, that's put next to it, and help to turn that pain signal off.
Is this computer run by battery?
So this computer actually is the battery itself. So the battery is built into it, and in many cases, these batteries can last anywhere from 5 to 10 years without ever having to be recharged.
But they can be replaced if you have to.
Absolutely.
Or you'll come up with something new by then.
Maybe, maybe. Technology keeps evolving, right? That's why we're here today.
Yes, it does. So, all right. Why do we use it for what types of pain and problems in the spine?
So a lot of times, and I'll give you an example. You have, a young, healthy individual who's either working in the coal mines or, was working in a factory, and they ended up getting hurt.
Yes.
They had some kind of trauma to their back, or they were in a car accident and they had some kind of trauma to their back, and they ended up needing to get surgery. Mm-hmm. And so that was to preserve their daily function, but now they're having secondary ongoing pain, which is limiting their ability to work on a daily basis.
So most of these people have already had surgery on their back in most cases?
In some circumstances they have. Okay, in some circumstances they've had trauma to their back, and now they're having ongoing leg pain that's no longer controlled.
Sciatica.
Sciatica is a different type of pain, and we'll get to that. But
we got all kinds of pain.
But yes, but it's similar in the way that we take the approach.
Okay. So you talked about the peripheral nerve stimulator. What conditions cause you to need that kind of treatment?
So a lot of times what happens is the pain generators in your body, right, the nerves in your body or the joints in your body, they either get over or under stimulated based on the trauma that it's experienced. And when that happens, the way your body recognizes pain sometimes can get confused by the way your body approaches managing that pain. So previously, when we used medications, we used to try to use that to mask the way your body experienced pain.
And that has led us to the opioid crisis.
Yeah, unfortunately, that's contributed to that. And the sad part about that entire situation is that when all these things happened, people wanted to continue to function as they were before. They wanted to continue to do their chores or to go back and work like they were previously, and they ended up taking medications to try to cover and mask some of these things. But what happened is that slowly the body adopted to that medication they were taking, and those medications failed to work. And so now that individual could no longer function. And so that's kind of why we had to take a step back and see what can we do functionally to help restore some of these things.
So pain is also the body sign to your overdoing it. in some cases. Okay.
Yes.
So you're trying to get rid of some of the pain, but can you overdo it and stimulate?
So can you
Yeah.
overstimulate? Absolutely. I mean, overstimulation, so there's a lot of safety measures already built into it. Anytime we do an implant like this, the really neat thing about these devices is that we do actually a trial before we do the permanent surgery. So
Okay.
it's kind of like you get to try the surgery before you do the surgery. And the unique thing is that you come in for the trial, we take the same kind of approach, but there is no permanent device implanted anywhere. And you get to experience what is called a paresthesia or a non-paresthesia based approach.
So I can envision where there are children or teenagers, not just adults, that have been injured in a car accident or have paralysis of some nature. Is this treatment good for them?
So most of the individuals we work in are, the elderly or mid-aged individuals. But in children or younger individuals, say they had like a gymnastics accident or something like that, or a football injury, and now they have something called, a complex regional pain syndrome. And those
Give me that name again.
complex regional pain syndrome.
Okay.
So CRPS or causalgia, right? So what that means is that in certain areas of their body, wherever the injury may have occurred, they're experiencing uncontrolled pain signals, right? Sometimes they can have like a discoloration of that region because of that nerve stimulus. And so that's where we have a really unique type of spinal cord stimulation therapy called a dorsal root ganglion therapy available. And a lot of times what that means is similar to a spinal cord stimulation therapy. It's an advanced version of that, if you want to say it that way, is we actually go to the dorsal root ganglion area in your body, which is right next to your spinal cord.
So you go centrally and not peripherally.
So they're all central approaches, but this is slightly more peripheral
Okay.
to the central approach. And basically, it talks directly to that area, and it helps to control localized pain a little bit better. And so we've seen folks, that have had inability to use their feet after a trauma because of that,
Yeah.
be able to, again, now reuse it. Also, we have to combine this with physical therapy because that's important in retraining those muscles to regaining some of that strength, to getting better and back to full health.
Is this a treatment for neuropathy?
Absolutely. We've had people with, for example, diabetes
Yes.
that have done great with these technologies.
Interesting. That's big time. And it's
It
going
really
to get
is.
worse, particularly in West Virginia, because so many people have it. Very interesting. Oh, keep going. I interrupted.
So, for me, the reason I'm so passionate about these technologies is because I feel like it really gives our patients a second chance at living a more fulfilled life, especially with, what they are able to do once these technologies have been implanted and available to them. And again, these have to go hand in hand with, changing their lifestyle, working actively with physical therapy so that they can meet the goals that they really have.
You mentioned physical therapy. So you're treating the pain system, and you want them to be able to do more physical things. So physical therapy must be very important.
Oh, absolutely. Absolutely. Always, people will come in and say, hey, doc, I had this issue going on. They sent me to the physical therapist, but it was so painful I couldn't take part in it. And I'm like, why would we refer somebody initially to physical therapy if a person is in pain and they can't take part in it? And that leads to the patient's dissatisfaction. They become, unmotivated. A lot of the times I tell my patients that why don't we come in, we try to do an interventional-based approach where we might need to just do a simple injection. And if we do that injection like an epidural steroid injection, and now you're able to take part in physical therapy, now you can regain some of that strength, strengthen some of that core, and return back to your job in a more effective way.
So you're trying to prevent them from having to go all the way and still be functional.
Absolutely. I think you have
That's
to take
a good approach.
You have to take a gradual approach so that they can get back to full function. Because a lot of times, if they go gung ho and they want to go back to full function, they might end up injuring themselves if they've not taken that physical therapy-based approach to re-strengthen their core.
Oh, so let's say I had a problem, I didn't do the physical therapy, and you did this right away, I might overdo it and cause injury.
What do you mean overdo what right away?
I mean, overdo physical things or something
Yeah, I mean, I think
that I shouldn't have done.
so. Pain is your body's way of saying that something you're doing may not be the
protecting
right
you.
thing to do, right? It's a protective mechanism. But at the same time, it's also, putting you in shackles at some points and not allowing you to do the things you really want to do. And so I think it's a balance between appropriate physical therapy and appropriate interventional care therapy to meet those daily goals.
That's amazing. That's amazing. So obviously, as you mentioned, most of your patients come from referrals.
We get a lot of our folks coming in from referrals. One of the most common sources of pain that patients are coming in with now is something called SI joint pain or sacroiliac joint pain.
We've heard of that.
So a lot of these patients, they will come in and say, hey doc, when I sit for a prolonged period of time, I have pain in my back. It radiates down to my leg, by my knee or towards my groin. And I just can't sit still for a long time. Or if I stand for a long time, it hurts. Or I toss and turn at night. And you feel pain really right in your lower back, near your hip or your SI
and
joint.
It just goes right down your leg. I've been there.
So sometimes it goes down. So sometimes it goes down your leg. But specific for SI joint pain, that's something we've seen a lot of great success with recently. One of the ways we've been taking that approach is actually doing something called an SI joint injection to identify the nerve to make sure that it is the correct nerve that we're trying to treat. And then we found that by using simple implantable technologies like this, typically this is made out of a bone graft material, and it's actually put right in the SI joint region. So right here in the SI joint region is where we put it. In between your sacrum and your bone right here is where we put this.
So you're increasing the space and taking
Absolutely.
pressure off
Yep.
the nerve.
Yep. Like Dr. Tim Deere always says, it's always a game of millimeters. So by taking some of that pressure off those nerves,
Yep.
it helps to take some of the irritation that they're getting. And this is more of a permanent fix to this issue. And that's the beauty of this, that, a lot of times we've seen success with this, that when we provide this kind of implant and it's minimally invasive, so there is really no recovery. The recovery time is typically about 2 weeks when patients feel that, and then they go back to physical therapy and they fully recover. They come in, again, for same-day surgery with these things. So the surgery, anytime, it takes between like 20 minutes to an hour to do the procedure, and they go home the same day.
So you identify the vertebra and the space where you need it. You do that by injecting.
So
you
we do
numb it, or you
injections.
do it by steroids.
So we do a combination of both. So one is a physical exam is a big component of it. The patient's symptoms obviously are a big component of it. And then the next thing is, using appropriate imaging based on that to make that diagnosis. And then to see how well do they respond to injections. If they didn't respond well to injections, then the chances of this therapy being successful for them is not appropriate either. We want to make sure that if they're responding well to injections, but if the injections are not lasting long enough, then we can approach it in a different way.
Can you tell by doing the little pinprick thing in the areas where the pain is? Does that tell you what area it might be?
Not necessarily.
Okay. Do X-rays show you if there's a
So,
thinning?
so X-rays can show us, arthritis in the joint. X-rays
Yes.
can show us, narrowing of the joint. So that's really important. But again, the patient's day-to-day symptoms, their functional goals, those are the most important things we take into consideration, along with the physical exam.
So are there some conditions that if you can eliminate the pain, you may eliminate or prevent further surgeries of that area?
Absolutely. Absolutely. So one example of this is spinal cord stenosis.
Yes.
Okay, spinal cord stenosis, typically a patient that comes in will say, hey doc, when I walk for like longer than 5 or 10 minutes, my legs get really heavy. I feel weakness in my legs. I feel tingling going down my legs. Most commonly, the patients will say, hey, when I go to either Walmart or Kroger, where I'm shopping, I have to lean over on a shopping cart. We call this a shopping cart sign.
They lean on the cart. You see them leaning
Yep.
on the carts.
And that makes it better. So the reason that is, and the spine model kind of helps to demonstrate that, is that the area in between your spine, in between the bones right here, where your spinal cord is, it can get compressed over time. Whether it's through the growth of something called ligamentum flavum hypertrophy, which is a tissue right there, or whether it's because the movement of these bones. So sometimes these bones, they move back and forth in between this space. That's called spondylolisthesis. So when that happens, it squeezes on those nerves. And
well, sometimes aren't these vertebrae the iliacs are fused?
So sometimes with arthritis, you can have some of degeneration there, right? Sometimes people go in and get a bigger surgery called a fusion. But prior to doing some of these bigger surgeries, this might be an option for our patients. And so one of the more unique tools that we're using now is called putting a spacer in. And so we actually take a lateral approach and we put a spacer in right in between these joints. And so once the spacer is put in, what happens is that it gets secured in the space and it prevents it from collapsing like this.
Are those made out of titanium?
They are, and they have a little bit of bone graft material in there, so this makes a full, permanent, secure area.
Bone graft material. So that stimulates more bone to grow, or is it just a spacer?
So it is a spacer, but it also actually causes bone growth there. And it forms a bone growth area right here for the patient, so that even in the event that, theoretically, if you were to remove this, there would be bone graft material present for the patient. So the response they're actually getting is because of the secure closure that it's actually creating here, which prevents the bone moving back and forth and preventing that nerve compression from happening.
So somebody might have more than one of those in?
Absolutely. So it depends on,
And are they different sizes for the different areas?
Yes. So we use a specific thing to measure that area.
Yeah.
And again, it could be depending on the imaging for the patient, depending on their level of physical exam, and depending on their specific needs. Some patients are fine with one, some patients need more than one. But the beauty of all these therapies is that you're not burning any bridges, so that should they need a bigger surgery in the future, the surgeon can simply take these out and do a bigger surgery if need be. But at least it allows them an option of a minimally invasive approach that requires just about an hour's worth of surgical time and same day discharge from the hospital.
That's phenomenal. That's phenomenal. So this is something that has been evolving over several years. All of this
Absolutely.
didn't just happen right away.
No, it didn't happen overnight.
And they're using technology that was developed for other areas and figuring out to use it in your case.
Yeah, I think, the huge benefit of this is I think the entire field of medicine as a whole actually is taking a more functional approach. And so it's what is the goal of the patient, right? I'll seldomly ask my patients, what is their pain score today? Because I think in many ways that doesn't tell me what their goals are. It just tells me a number, and I find that to be in some ways quite irrelevant. And so the way we take that approach is, we ask our patients, what is your goal for betterment? What is your goal? Do you want to be able to, go with your kids for a walk, or do you want to go for a hike,
or drive 200-mile trips,
or drive 200-mile trips? A lot of times we'll get patients say, Doc, I can't even take a trip up to Morgantown to see the football game because I can't sit for that long. And that's typical of SI joint pain. Or, hey, Doc, you know what? I can't go shopping anymore because I have to because that buggy no longer supports me, and I have to take the electric wheelchair or something. And that's related to spinal cord stenosis. So a lot of these different things, again, are about the patient's goals. What does the patient want to do to get better? And what can we do? What small role can we play in bettering their life?
So tell me, on average, what are the most common patients you see? Are they the sacroiliacs? Are they the injuries from a car accident? What are the most common patients?
So I think that's a challenging question to answer, only because, again, the most 3 or 4 main things, right? Again, low back pain,
yes,
pain that radiates down their leg, right? Or just SI joint pain.
Yes.
Those things are pretty typical, but it really depends on who's sending those patients. So oftentimes, patients feel helpless. They feel like they don't know what they can do. And they need to actually talk to their primary care doctor or their surgeon and say, hey, doc, I'm feeling this way. And those primary care doctors or those surgeons, they're really well trained to guide them in better therapy. And so I think the patient should not feel helpless. The patient should feel that there are tools beyond medicine available to help them, beyond pharmaceutical therapy. Because a lot of folks don't want to go down that road because they know that what opiates have done to our society.
Yes.
And so we have solutions to help guide them in the right direction.
So you're the in line for a lot of these patients, and they don't realize that there's something above their family doctor or the physical therapist or their regular orthopedist.
Yeah, I think in some cases that's the case. The field has rapidly evolved, and it looks a lot different than it did 20 years ago. And I suspect that it'll look a lot different in the next 5 years and beyond. And it's because, we're figuring out how to use really great technology, but also at the same time target nerves rather than giant symptoms. Before we were known as pain doctors, right? And now we've evolved to spine and nerve physicians. And that's because we're able to figure out how to crosstalk with some of those nerves and to improve our patients' quality of life. And I'll give you one example. I had a really close friend, who got hurt. He worked in the coal mines.
Yeah.
And as a result of that, he felt horrible. He had kids, he could no longer provide for his family. And one option he had was, can I just keep taking medications, by mouth and, continue to work, or what else can I do? And that truly almost destroyed his family until we were able to offer him interventional approaches. And as a result, he was able to come back to his job, to live a more fulfilled life, to continue to be a role model for his kids and for his community. So I think that's the approach we need to take, because this is for our patients. It's to make their life better.
The question now on the spacers, can those also be used in the NIC area? And are there reasons to use it in the NIC area?
So in the neck, so far that technology is still being studied. We've not developed these type of spacers to be used in the neck area. Typically, these are used in the lumbar vertebrae area because typically those are the areas that actually impact and have seen most of the degeneration with a lifelong of hard work.
Quick question. In car accidents, which is the most common injury that happens to the spine, the neck, and the head?
So that's a really difficult question to answer. Right? Depends on how fast the car is going, how fast the car is going, whether the patient was wearing a seatbelt, hopefully they were, whether the airbag's deployed, the momentum of injury, the site of injury, that's difficult to answer. So car injuries are a big source of some of these problems. Even trauma early on, like falls early on, falls after a sports injury. Those are all issues. So our patients aren't just patients, who are 75 and above or 65 and above. We're seeing more and more younger patients wanting to take minimally invasive, safer approaches to care.
Okay, question now. This is very impressive. I have learned a whole lot, but is this somewhat expensive, and does insurance cover this type of treatment for a patient?
So I think, the beauty of this is that a lot of insurances are moving forward with more functional-based care, and they want to see their patients get better. And so they're working with us to cover a lot of these technologies and these interventions. And again, the first step is just approaching us or approaching your doctor and saying, hey, this is my problem. These are my goals. What can we do to work together to get better?
And is this type of technology available everywhere in West Virginia or in the United States?
So we're truly blessed that we're one of the few places in the state to offer these technologies today.
Fantastic. Well, I have to tell you, I have been very impressed. I've learned a whole lot. I have some of the symptoms, and I want to thank you for taking your time out of your very busy practice to be on our show. This is Dr. Richard C. Rashid, hoping you'll see a great day.